Alright guys, this is the first of the lectures in place of the 5-1 class period that will be online. So this is bipolar, and we've actually covered a bit of this already. So again, what I've said for the last set of lectures with depression and schizophrenia is that mental health disorders are often a spectrum, and we're using a lot of the same drugs for a lot of the same conditions, which makes it a little bit confusing, I think, but also streamlines things a little bit because it's really, at the end of the day, about treating symptoms. And oops, to remind me later on that one. And then, so if you have, a person who's bipolar, but also maybe has psychotic features, you'd maybe want to consider an antipsychotic. So just think about it that way, and try and focus on the symptoms, and then not get too caught up with the specific diseases. However, we'll talk about the specific things that are really just kind of in bipolar's wheelhouse here. So bipolar is a difficult disease to diagnose, and I touched base on this during depression, that oftentimes you get people who have components of depression that is the primary driving factor behind why they're maybe seeking help, because their depressive phases or depressive components of the disease are the ones that are being primarily the most problematic in their day-to-day life. Whereas when you have manic phases, some people may actually enjoy them or find that they're productive. So really, the problem with this is that it can take a lot of time to find out if somebody is actually bipolar, because and some people just can't. It's very difficult to tease out those features until maybe you start treating their depression, and over time their mania starts to get worse and worse, and all of a sudden, they're having maybe more aggressive manic episodes than they ever did before they were treated. And that can happen when you treat somebody with bipolar with just antidepressants. So, when in doubt, it's always best to either, consider psychiatric referral if you aren't sure, if you have, somebody reporting depression, or, definitely consider just covering your bases and making sure you're asking the right questions. So there was a study out there a little bit ago that showed that up to 35% of people who are bipolar actually waited about 10 years for the correct diagnosis. So I think we're better about it now than we probably were when the study was taken, but it's still something that is a big deal, I think, in the mental health community. Features. So you have major depression, so just like the things we talked about, specifically suicidal ideation and behavior, and then either mania or hypomania, something on that spectrum. Mixed episodes also can be depression and mania happening relatively quickly, within short intervals of each other. And then you can also definitely have a psychosis component. Full-on manic episode, it's not uncommon to have some psychosis involved with it. Sort of goes hand in hand with what's happening with the mania. You can also have people who have sort of a hybrid between bipolar and schizophrenia called schizoaffective. And when you read about, if you do go into psych or do more research about schizophrenia, you'll read that it's sort of a spectrum of different aspects of it. And when it comes to schizoaffective, it's basically, you can look at it either one way: bipolar disorder with psychotic features, or you can look at schizophrenia with manic episodes and manic depressive episodes. So bipolar 1 is kind of the classic bipolar, where you have major manic episodes and major depressive episodes. You might have some hypomania thrown in too, but the big qualifying factor for bipolar 1 is that you have those really strong manic episodes. For bipolar type 2 is major depression with hypomania. So there's no real manic episodes, there's no mixed episodes either. And it's again, the bipolar type 2 subset is the one that's the hardest one to diagnose. And then there's cyclothymic, which is rapid cycling. And these people basically have a lot of hypomanic or depressive symptoms within a brief period of time. So usually periods lasting like 2 months, and they'll have these kind of rapid cycling of variety of depressive manic phases, and then they might be symptom free for quite a while. And these are usually not significant enough symptoms to have a major effect on the person's day-to-day, so they might not even meet, again, major depression criteria, but they can still have some symptoms that are probably worth treating. And then NOS, or not otherwise specified, is really just because bipolar is complicated and not everyone fits into one of these boxes. So you might have, bipolar type 1 person with rapid cycling. You might have bipolar type 2 with an occasional full-on manic episode. So there's very gray areas within the diagnoses. So a lot of times you see just kind of bipolar, NOS as a pretty common diagnosis in psych. All right. So when we treat people, we've talked a lot about treating depression. So let's talk about mania and what we're trying to do. So mania is really associated with an elevated or irritable mood lasting at least 1 week, and usually it's associated with grandiosity, lack of sleep, excessive talkative. If you ever talk to a manic person, we have a pretty big psych unit at Abbott, and I've done some intake admission discussions with some manic patients, and yeah, they're you can tell really quickly if somebody's in a manic or even a hypomanic phase, because they're quite talkative compared to maybe the average person. And buying sprees, like impulsive behavior, it's not uncommon for somebody undergoing mania to spend tens of thousands of dollars to blow their life savings in a couple of days buying random stuff that they otherwise would never even think of buying. Hypersexuality can be really problematic. So promiscuous behavior can put people at risk for things like unintended pregnancy, STDs, and other things as well. Flighty ideas, just very scattered thinking, and goal-directed activity. So can be very focused on a certain thing, like we have to get this done, like very intensely adamant about certain things. Hypomania is really the same thing, however it's shorter, so usually about 4 days, and it's just less intense. So you get a lot of these things, but it's just not going to usually affect your social functioning. Somebody under a full manic episode is usually not going to be able to, if they go outside of their house and start talking to people, people are going to be like, well, probably something off with that person. A hypomanic person actually could probably be very functional. If you think about minor things like this, so maybe you're sleeping a little bit less, or you have these great ideas, you feel great about, you have these grandiose thoughts, but they aren't quite to the point where you think you're a god. You just think maybe you just like, gosh, I have really great self-esteem, or you just feel like you're really proud of yourself, or things like that make you feel good about, your life in general. So again, people can tend to like those hypomanic phases. 5 to 15% of people who have hypomania may transition to mania. So this is where things get tricky and where our diagnoses get a bit mixed, because you can go from a hypomanic state to a manic state, and even somebody without history of mania who undergoes hypomanic states occasionally can still transition into a manic state as well. So you end up with people who are at risk for this, and you further possibly increase that risk if you just treat the depressive angle. You can actually push people into a more severe manic state, or augment their hypomanic state that already exists. And then a mixed episode, I've talked about this a couple times. Basically, you have full manic and major depression met within the same 7-day period. So you have it within a very tight window, where normally that's not real common. You usually have one or the other. Mixed episodes is very much kind of the what you'd maybe think of as the roller coaster effect, which sort of like this. So this diagram this diagram is kind of silly, but does show you a bit of the differences. So if we see everybody, normal people who don't have mental illness, kind of just have this funny the way they put the good times and the bad times. So you get your normal mood swings, which happens with life, and then manic people, there's hypomania and subsyndromal depression, which most people won't experience, and then you have the full-on manic and the full-on major depression. Okay, so what do we want to do? We want to restore the disrupted mood, so that only 1 or 2 symptoms are mildly present at most, and we want to have, if there is psychosis, we want to completely resolve that. Restore our sleep patterns so we can help people with energy levels so they don't crash after their episode. We want to empower the patient to be able to function, socially and professionally, blunt the episodes if they cannot be eliminated altogether, and ultimately minimize hospitalizations too. Lithium is one of the only drugs, although it does have some use for augmentation in treatment-resistant depression, and I talked about a little bit with clozapine therapy, and can help with schizophrenia too. Its primary role is a bipolar agent, and it's really kind of an odd drug because it doesn't really have a mechanism of action. It's not really in a class per se. It's sort of its own thing. So lithium salts usually come as lithium carbonate, but it's really just ionized into the element, and it's been used for over 70 years for psychiatric conditions. It's one of the older drugs we have, and it's still actually pretty useful today. What it does is well, I said we don't really understand the mechanism all that well. We do think it alters various cation transport across cell membranes, which makes sense because it's essentially an ion. It's very similar, if you remember your periodic table, to sodium, and so it can move in a similar fashion too. But it seems to have much more influence in the central nervous system. It's thought to affect reuptake of a couple neurotransmitters, specifically serotonin and norepinephrine, maybe some dopamine inhibition in the postsynaptic space. So that might keep those manic episodes from swinging high on, like, if you have a really big dopamine response to a manic episode. Intracellular secondary messenger systems, probably lithium, again, being a very interesting medication or compound itself, just being sort of an ionized element. It's going to have a lot of effects in the body, and a lot of things that we probably don't really understand and probably never will. So lithium itself, why do we still use it? It's old, but it's a really effective drug, and it's got a narrow therapeutic index, which is probably the biggest downfall, but it's one of the most effective medications for acute mania. So it comes as a form, Lithobid's kind of the brand name, but lithium carbonate's the common salt, and it comes as a couple different forms: immediate release and extended release tablets. It comes as an oral liquid as well. It's really well absorbed. It's widely distributed. It's got about a 1-day half-life or so. It is renally cleared, and about 80% of it will be resorbed because it's very similar to the way the body clears and processes sodium. So because of that, you have to be really careful with anything that's going to interfere with renal clearance. So specifically diuretics, ACEs, ARBs, NSAIDs are probably the biggest ones to think about that can affect lithium. It's not that it puts the person at danger per se, but you have to make sure you're monitoring the levels, and hydration status and salt intake can also be problematic. So people who are maybe young adults or older adults, either who are exercising regularly and losing a lot of fluid. If you sweat a lot, you can end up with a significant water fluid balance change, which can cause changes in the lithium level. It can concentrate the lithium. It can put you at risk for toxicity. Things like NSAIDs can decrease lithium's elimination from the body as well. So we try and avoid, not necessarily avoiding all NSAIDs. PRN is probably fine, but scheduled NSAIDs would be a problem with lithium. Reducing risk of suicide. It actually is one of the only medications that has studies behind it that shows that it reduces the risk of suicide for these patients, which is pretty cool. It is, again, highly effective for manic episodes. Some of the side effects, when you have it in its standard therapeutic range, you actually don't have too many side effects. Pretty well tolerated. However, because it's kind of like taking extra salt, people do get maybe thirsty. It has been associated with some weight gain and maybe cognitive impairment, kind of on the higher end, but that would be not all that common. Chronic toxicity would be renal failure, and that's debatable. There's a lot of questions on whether lithium actually can cause renal failure, or if just because people who have renal failure also kind of have lithium toxicity as a comorbid side effect to that, because if they're on lithium and their kidneys start failing, they're going to accumulate. So it can be difficult to tell, was their level elevated before they went into renal failure, or was it elevated because they went into renal failure? And I don't think there's great evidence to support that lithium actually causes kidney toxicity, but it is something that's listed and something that's theorized. And then also thyroid issues is probably one of the biggest chronic side effects. So it may cause goiter by it inhibits the TSH receptor. You have about 15% chance of having this on long-term therapy. And it is pregnancy category D. It can be used in severe situations, but most of the time we try and use something else. So again, I don't want you to memorize any of this, kind of just for your information. Only thing to know or remember is that lithium has a narrow therapeutic index and does require blood monitoring. And I just wanted to put this on here because it's sort of interesting. So with mental health patients, one of the things you always concerned about is an overdose. So if you give somebody lithium and they overdose on it, you kind of want to know what to look for. And just to show you how tight lithium's window is, usually you're looking at targeting a blood level of about 0.6 to 1.2 for acute manic episodes. and a little bit lower than that for maintenance. So every 4 to 5 days during initial therapy, you're going to check a level, then twice weekly until you're stable and the patient's stable clinically, and then about 1 to every 3 months thereafter. So you're never just letting somebody's lithium ride for like a year without checking it, or you shouldn't be. It's just too big of a risk. So if we're looking at acute mania 1.2, maintenance 1.0, it doesn't take much increase in your level to get to the point where you're having GI side effects and tremors. And it takes about a doubling of that to get confusion or somnolence. Can you imagine if you accidentally doubled up on your lithium dose for the day? You could get to the point where you're quite tired, even experiencing some altered mental status. And over 2.5, you can get seizures and you can go into a coma and potentially die. So it's quite toxic. And as far as treating it, we can give IV hydration. So if you have, some of these if you have an elevated level and mild symptoms, IV hydration is probably fine. If they have greater than 2.5 with any type of symptoms, we're probably just going to send them straight to dialysis. Lithium dialyzes off nicely. And if it's greater than 4, regardless of the symptoms, we want to get that out of the body before it can cause any problems. So we send them to dialysis. Anticonvulsants are the other really good option. So these are mood stabilizers. So you'll hear these called mood stabilizers as opposed to anticonvulsants or AEDs because they aren't used for epilepsy in this situation. However, that's what they are and what they're originally designed for. So in addition to lithium, the only other medication approved for acute mania is valproic acid. So we do use Depakote quite a bit for these patients. And there are several others that are not effective for acute mania, but are fine for maintenance or initial episodes of bipolar 2 if they aren't having just maybe a hypomanic episode or a mixed hypomanic depressive episode. So you have carbamazepine, lamotrigine, topiramate, and gabapentin have all been studied and have all been used. As far as primary agents, we'll kind of talk about that in a little bit here, but some are more preferred than others. So when it comes to antipsychotics, we talked about acute mania maybe having a psychosis component. So if somebody is manic and they have psychosis, the first thing we probably want to do is actually address that psychosis component first, because that can be dangerous for patients and can be dangerous for hospital staff if somebody's in the hospital, or for caregivers. So controlling that is important. And you can do this at the same time you're working on the bipolar too. So you can give somebody, olanzapine or haloperidol if it's really bad, or you could start them on a drug like risperidone if you want them on, it's not so bad they need something urgent, but maybe you want to get them started on something anyway. And you can combine those with lithium or Depakote. That's the nice thing about these quote unquote mood stabilizer medications. The anti-epileptic drugs are sort of on their own tier and have their own whole set of mechanism of actions. And a drug like lithium is totally different too than our antipsychotics. So with antipsychotics, we can double up on them, but we rarely do. But instead, we like to mix them into a mood stabilizer regimen. You can also, some of the antipsychotics are actually approved for monotherapy for hypomanic patients. So that's a newer treatment strategy that people have been using, is just like, let's start somebody on risperidone and call it good, or start them on aripiprazole and call it good for hypomania, so bipolar type 2. And in that case, they wouldn't even be on a mood stabilizer. So first generation options, haloperidol, of course, will work. You don't want to use it long term. And then second generation is going to be much more common. So these 4 have been more or less studied, but some newer medications like asenapine, lurasidone, and paliperidone are all indicated as well and used for this purpose. So for treating somebody who's acutely manic, you're going to look at starting lithium or valproic acid. So that can depend on how the person presents. Lithium does not come as an IV form. So sometimes valproic acid, if somebody is really manic and refusing orals and agitated, irritable, valproic acid might be ideal if you can get them sedated potentially and give it to them IV. Otherwise, haloperidol, or some kind of a second generation antipsychotic. You could give them IM haloperidol, you could give IM olanzapine, and that can be an effective way to calm them down quickly and not have to rely on the oral route of ingestion to take time to work. But either way, no matter what you do, you want to use both most of the time. So, if somebody's just acutely manic and they're relatively pleasantly manic, I should say. If they have lithium or valproic acid, if they're willing to take those orally, that should be fine, maybe by itself even. If they have those psychotic components, that's when you're going to combine. And a lot of times they have some sort of psychosis going on too. Not all the time, but a lot of the time they do. Hypomanic patients. So if somebody's hypomanic, we like to use a drug. We treat them kind of like we would treat a schizophrenic patient initially. So risperidone is a good initial starting drug for this. You can also use our, and this again, we're talking about acutely. So this is somebody who's acutely hypomanic, which is kind of interesting because you don't generally see somebody present in acute hypomania because they aren't to the point where they need to go into for medical attention. They're usually fine. But if you did get that sense, then risperidone, you could also use any of the other ones too. Lithium, valproic acid are just fine. I would stay away from haloperidol and stick to second generation antipsychotic though. Even though haloperidol would work and is indicated, again, we talked about the reasons why it's not really preferred. So you'd continue one of these strategies for about 2 to 3 weeks, and after that, if you didn't get a response, if the person's still having manic episodes, you want to switch from lithium to valproic acid or vice versa. If they were hypomanic, so it depends on which one you started with, right? You don't use lithium and valproic acid together usually. But if you were to start with lithium, maybe try switching to valproic or etc. If somebody had lithium or valproic, or if somebody had risperidone, like if they're hypomanic and you started them on risperidone, you could add either lithium or valproic acid. So you want to continue this until something works. You could, I think, theoretically use lithium and valproic together, but most people would recommend kind of using that mood stabilizer and then combining it with a second generation antipsychotic. Okay, bipolar maintenance. First line monotherapy for maintenance. We can use lithium and valproic acid again, but Lamotrigine comes into play here. We talked about this being a really well tolerated anti-epileptic drug. The biggest issue with Lamotrigine and bipolar, just like with epilepsy, is the time it takes it to get to a dose that's going to be therapeutically beneficial for the patient. So remember, we have to ramp it up really slowly because of that Stevens-Johnson syndrome risk. The other thing you can do if somebody, for example, is under an acute hypomanic episode and they respond well to oral risperidone, you can give them a long-acting IM. That's what the IM form is, long-acting. Give them long-acting risperidone. Second line options: aripiprazole, quetiapine, olanzapine. And you could probably put like lurasidone in here too. Yeah, there's a number of other ones that you could probably use. 4 weeks suboptimal response. You're going to use lithium valproic. You're going to combine with a second generation antipsychotic. If you haven't done that, you could combine lithium plus the AED. So we talked about this not being all that common, but you could do it. You could do all three. So you could do lithium, AED, and then plus second generation antipsychotic. So you can combine everything if you want to. No real problem with that. It's just a lot of medications. So you want to try and minimize the amount of medications you're giving the patient, but you also want to treat them effectively. So that's pretty much it for bipolar. Again, we talked about a lot of these medications already, and really you're looking at finding a balance between what's going to work for the patient, what's not going to cause a lot of side effects. Ultimately, there's not going to be a perfect regimen that works for everybody, but you have a number of options to mix and match here. One question I get is, do you use antidepressants ever? And you could potentially, but what you'd really want to make sure is that you've got that bipolar component controlled decently first. If you've got the manic and hypomanic episodes in order, and somebody's still having really major depressive swings, then you could maybe consider adding like an SSRI on, but you wouldn't ever want to start that way. That's always want to be kind of the last thing you're targeting. And a lot of times these patients, like a drug like lithium or valproic acid, it not only works well for the acute manic phases, but it does usually work for people with depression too. So it helps with those, or people with those depressive symptoms as well. So it does help both sides of the bipolar. So normally you don't need to, but you could, theoretically add something like that on if you needed to. So, all right, that's it for bipolar. We'll talk about ADD in the next lecture.